Good evening. I'm John Gorman. I am the Communications Director for Maryville, and I'm sitting in for Sister Catherine Ryan, our Executive Director, who's under the weather tonight. Joining me today is Dr. Barb Preib, and she is the Executive Director of our Scott Nolan Hospital and the Chief Nursing Officer there, too. Welcome, Barb.
Well, thank you. It's a pleasure being here this evening.
Barb joined us earlier this year after an extensive career in nursing, teaching, and the treatment of the mentally ill. First of all, Barb, tell us a little bit about yourself, where you're from, your family.
Sure. Well, I'm a native Chicagoan, grew up in West Rogers Park, attended the Immaculata High School, went to DePaul University for my undergraduate degrees, then went on to University of Illinois for my master's in administration, and finally my doctorate in nursing practice at the University of Illinois. So I couldn't stop with that, and then I went on and obtained my certificate as a forensic nurse specialist, and then went into the area of becoming a sexual assault nurse examiner, both for pediatric patients, and then a second course, sexual assault nurse examiner for pediatric patients, adults and pediatrics.
That's the SANE program, is what that's?
That is,
okay.
Correct,
Okay. And family? Tell us a little bit about yourself.
Sure. I'm married of 22, almost 23 years to Edward Lannon, who I know is watching tonight with my two little daughters, Teresa and Elizabeth. So enjoy the show.
Good. Thank you. You've had pretty deep roots in the Chicago community, and you worked at a number of hospitals in Chicago before you joined Maryville.
I did.
Tell me about where you worked and what you were doing in your early career.
Well, I first started out after graduating DePaul in the operating room at Rush Presbyterian St. Luke's because they always suggested that you be grounded in surgical or medical surgical nursing before specializing. And it was my desire from freshman year in college to go into the mental health field. I ran into an excellent counselor at the time who told me either if I wanted to pursue that degree, that career, I would have to get a PhD in psychology, which I didn't think I could do, or become a psychiatrist. And back in the day when I was in school, the field for psychiatrists, women psychiatrists, was not open. Or the other thing was to become a psych nurse. And so I thought, well, you know what? I think I can do the latter. My mother was a nurse, and my father was a graduate of DePaul. So I transferred from Northwestern sophomore year and got right into the DePaul University College of Nursing program. So going back to my career, started working at Rush in the operating room, saw the first kidney transplant, which I believe was done by Dr. Jensick in 1973. Enjoyed the operating room, but sort of didn't get a lot of communication with the patients. So went to med-surg for about a year, and after that I felt I was grounded in the required medical surgical arena, if you will, and went on to Illinois Masonic, where I started my career in mental health. And I moved up from staff nurse to head nurse to clinical director of the psychiatric services at Illinois Masonic. Then I went on to assume some educational and administrative activities at Augustana Hospital and Columbus Hospital, in both institutions, which I became the vice president for nursing services. And then after about 10 years of heavy-duty administration, felt that I wanted to get back into the clinical arena, and started back at the UIC, which is when I began on my doctorate, and went into practice with a psychiatrist, Dr. Bill McMiller, looking at joint ventures of developing mental health services in Chicago public schools, which I did for about 20 years. We had partnership status with certain Chicago public schools, and what we would do is go in and first open up a medical clinic, and then I would come in and develop the psychiatric component of the program. And it was like having a psych clinic on wheels. Most of the schools that I serviced were in under-resourced, low-income areas, so my caseload was quite challenging. I spent much of my time working directly in the projects, the Henry Horner projects, the Harold Ickes projects, Robert Taylor projects, all of which was a very rewarding experience, especially in working with the children and the families.
Well, how did you happen to decide to go into the mental health field? You made this decision as a pretty young student.
I actually did. I made the decision pretty much before I started college. As I mentioned, my mother was a nurse, and my aunt, who was a Chicago public schools teacher, took me with her to work pretty frequently. She had no children, and she, I guess, decided to become my surrogate mother. And I would see her in action. I would see her in those days, in the 50s. They didn't have all of these elaborate mental health counseling services. Mental health, especially child psychiatry, was practically unheard of in those days. And so watching her work with kids that probably had attention deficit disorder, but it wasn't diagnosed, or who had impulse control disorders or extreme anxiety disorders, I saw how she worked with the kids. And the blend of observing her and my mother being a nurse sort of led me into wanting to work in the mental health field, particularly with children.
So in those days, back in the 50s and early 60s, I think probably the education people thought, this is just a bad kid who's naughty. And I know the nuns, Sister Kathy, of course, accepted that nuns would, in my grammar school, would teach you their own brand of a discipline. But there were mental health issues out there. They just weren't being treated at the time, right?
Well, they weren't being treated, and they weren't being recognized. I think that if you look at the history of psychiatry, and particularly in view of where it stands with the other medical disciplines, it's down on the bottom rung of the ladder. And that's because it's just not been well recognized, and particularly disorders with children.
Dr. Preib, we have a caller who has a question.
Sure.
We'd like to hear from that person.
Hi, I have a question for the doctor. I want to know if there are alternative treatment methods besides medication for children who have attention deficit disorder or some of these other disorders. I've noticed an increase in children being put on medication, and I just want to know if doctors consider other treatments before going to medication, or is that really the best tool?
Well, to answer your question, first I have to say most clinicians will explore other alternatives before starting the route of medication. They will want to know a little bit of history about the child and whether or not there may have been some trauma involved in the child's development, which might be the precursor to the behaviors that are in terms of being treated. We'd look at family therapy, we'd look at individual therapy. However, with certain disorders, primarily the best response method is with certain medications, like the attention deficit disorders. The use of medication is to help stabilize the child so you can get the child to focus, and then look at more active interventions between the child, the family, and the teacher. So yes, there are other alternatives aside from medication.
Thank you for the call. Through the last, we'll say, 30 or 40 years, do you think that the stigma that's attached to mental illness has dissipated, lessened some, or is it still a stigma attached to mental illness?
Well, I still think it's a pretty strong stigma. People are still reluctant today to want to talk about mental health related issues. I think it's improving. I think people are becoming more receptive to the fact that we all have different lifestyles we've come from and have been exposed to different kinds of situations which may have an impact on our behavior or our self-esteem or our ability to deal with certain anxieties in the everyday workplace or the everyday interpersonal relationship. So I think it's becoming more acceptable to receive therapy, but I still feel there's a strong stigma associated with it, mental health.
When, in answer to the caller's question, you talked a little bit about the drugs. The drugs also have made tremendous strides in the last several decades as far as their efficacy. Is that not true?
Yes. In the 50s, when treatment of attention deficit disorder began with the stimulant medication, probably the only used medication at that time was Ritalin. Now there are two major categories of stimulants that we use with children: the methylphenidate-based stimulants, which Ritalin is one, and the amphetamine salts, which is a different category. It has a different chemical structure, but is also very helpful in the treatment of ADHD. And some examples of that medication would be Adderall tablets, Adderall XR. So there are about 10 to 12 different kinds of medications that are available for treatment with that particular disorder. Attention deficit disorders, as compared with one or two maybe back in the 50s and the 60s. So we've made tremendous strides.
And that's just dealing with that specific disorder you're
That's
talking
correct.
about. We're not getting into schizophrenia
No.
or bipolar or anything
Or depression.
other.
No.
Depression, right? But those that pharmaceutical solution, so to speak, has improved through the years, hasn't it?
Oh, definitely. Yeah.
When you were talking earlier about your mother and your aunt, you mentioned how one was a teacher, one was a nurse, but you're still teaching, are you not?
Yes, I have a contract with the University of Illinois. I was one of the first cohorts to graduate from the clinical nurse specialist in forensic nursing program. We received a grant and began educating nurses in the area of forensic nursing. As consequence of my graduation from the certificate program, I was recruited into teaching two courses. One was dealing with vulnerable populations, which crosses a variety of different patient cares, needs, and arenas, and also the clinical component for forensic nursing, where students need to put in 120 to 140 clinical hours of practice in a particular setting of their choice. So I do oversee the graduate level clinicals, and I coordinate those at various sites in the Chicago area, and I'm very interested in recruiting students to work here at Maryville, in our different centers that we have: crisis nursery, the Children's Healthcare Center, residential, and of course Scott Nolan, our acute hospital. I teach the course, the actual vulnerable populations. It's an online course. I usually do that in the evenings or on the weekends. This is the last semester that we're going to offer the program, so I sort of felt a need to tie that up.
Thank you. I'll put an ad on here for our hosts here, and while I'm asking you another question, you just mentioned Scott Nolan, which is where you're in charge, and tell us about what children come into Scott Nolan, the ages, what kind of maladies they come in with, and
Sure.
Go from there.
Sure. Well, we treat children anywhere from 3 years of age up until 21 years of age. The types of cases that we get pretty much cover the spectrum of child-adolescent disorders. As I mentioned earlier, attention deficit disorder, post-traumatic stress disorder, depression, bipolar or mood disorder, acute anxiety reactions, anxiety with disruptive behaviors, anxiety with depression, and then, of course, one of our largest categories, the disruptive disorders, which would include diagnoses such as intermittent explosive disorder, disruptive behavior disorder, and I'm blocking out on the third one. But yes, the disruptive conduct disorder, all the three different disruptive behavioral disorders. Many of our children that come into the hospital for hospitalization have additional complications over perhaps the child that is not coming from a DCFS unit or from a foster home placement. I want to say about 80% of our children do come from foster home placements or residential treatment centers. So they bring with them not only their psychiatric etiology, but also exposure to unstable family situations, failed foster home placements, exposure to trauma, witnessing the death of a loved one, gang involvement, just horrific kinds of domestic violence. So the children not only have active psychiatric etiologies, but also exposure to other at-risk factors, making them very vulnerable.
And many of these children have been abused.
Oh, yes. Physical abuse, emotional abuse, yes.
Sexual abuse, too,
Sexual
in some
abuse
cases.
as well, yes.
And we have, how many? We have 4 or 5 full-time psychiatrists there?
Yes, we have 3 full-time and 2 part-time psychiatrists.
We also have kind of a panoply of languages that they command, don't we?
Yes.
We have a Polish-speaking...
Yes, Dr. Tredowski is fluent in Polish. Dr. Benegas is, of course, Spanish. Dr. Budd is Urdu. And let's see, who else do we have?
Dr.
Shin, I believe, is Korean. And Dr. Lorit, I believe, speaks Thai. Yes,
right.
Correct.
So,
and just came back from Thailand, I might add,
oh, did he?
to visit his father.
That's a long trip. You said something that triggered, first time I was exposed to Scott Nolan, it triggered my inquisitiveness, and that's that we have children as young as 3 years old coming in that have to be hospitalized for psychiatric problems.
Yes.
That seems hard to believe. Could you explain that a little bit?
Well, sure. The first few years of life are critical in the child's personality development, the ego development, boundary development, socialization skills. And a lot of our children, unfortunately, are in situations where they may be victims of poor parenting, neglect, failure to thrive, lack of social interactions. And so when that occurs, the child develops sort of a pattern of abnormal behaviors or abnormal socialization patterns, or doesn't know boundary restrictions, or doesn't know how to engage with a mother or father figure or a peer. And they become very regressed, at times impulsive in their behaviors, very attention-seeking, because they haven't learned how to respond to normal social cues. So it is a very sad situation, and in some of those cases you'll see where children have dealt with issues in a very unhealthy way. We had one 3.5-year-old who actually strangled her pet bulldog to death. So they're very complex cases.
That's fairly grim. So how do the children come to us? What's the avenue that they get to Scott Nolan?
Well, a lot of them are referred through SAS services that are feeder units that refer children into our facility, particularly when they have a current active history of suicidal ideation, or there may be other significant behavioral concerns going on in the family. A lot of them are private referrals. Many are from our residential treatment centers, which is also part of Maryville. We have quite a few treatment centers across our Des Plaines and Bartlett campuses. A lot of them have heard of Scott Nolan and some of our physicians and request hospitalization.
How long would a child typically stay with us, if there's a typical?
If a typical diagnosis would be anywhere from 2 to 3 weeks. However, we have had children in the care of our facility for 3 to 4 months. And those, again, are probably more complex cases where the child is experiencing a relocation issue of going back to a foster home family or a facility where they can be cared for.
You mentioned SAS agency. I don't think perhaps our viewers know what that is.
Well, let me say it simply. SAS is a service, wraparound service, when a child is expressing a desire to hurt themselves. Prior to being hospitalized, it's usually a licensed clinical social worker comes out either to the home or to the school or to wherever the child may be living at the time, and does a mini evaluation of what's going on in terms of suicidal ideation, self-harm, what is the extent of their verbalized ideas, do they have a plan, do they have a method, do they know when they're going to do it. And depending upon the child's response, if it falls up in the high category where they have a plan, a method, and a time, and they know how they're going to do it, that's considered a more serious case. And the SAS social worker will call the different hospitals with mental health services and see if there's a bed to refer the child.
Thank you. I sensed when that caller made her inquiry that she was maybe talking about something very personal for her. These parents that arrive with a child most often comes in an ambulance by themselves or with an ambulance crew, and then the parent follows separately. Is that pretty accurate?
Yeah, that's generally the case, although in some cases the parents will come in with the child.
Just walk them in. But when that parent arrives, they're pretty distraught, are they not?
Oh, yeah. Distraught for a number of reasons. First is they have been enmeshed in a situation perhaps for the last few weeks, months, where they were unable to care for the child's behavioral needs. So that in itself was a high crisis, high stress level. And now they're perhaps, if you will, at their wits' ends, not knowing how to handle the child. Maybe there's a tremendous amount of conflict occurring in the family as a result of the child's behavior. And they want to bring the child in for care. And they arrive to the facility, and when they finally realization hits in when they come to the front desk and then go into intake and have to give up the child's belongings and sign consent for the child to be admitted, is a tremendous amount of guilt and loss of control for both the parent and the child. Think about trying to separate yourself off from a loved one, particularly a child who's dependent upon your needs and who's developed a bond with you. You're going to leave your child alone in a hospital, people you don't know caring for that child, telling your child what to do. And then I think comes the fear that you've been a bad parent, that maybe you failed or you've not done what you could or should have done to avoid the hospitalization. And all of those emotions and factors are intertwined at the time of the admission. And it can be quite a traumatic experience, both for the child and the parent. And it's very important at that time to provide reassurance and assistance to the parents and the child in the time of need to try to reduce the anxiety. And as I mentioned, some of the fears of guilt or failure at parenting, and in some cases where the parent might be a foster parent, fears of, well, will I lose this child because the child is now in the hospital? Will the Department of Children and Family Services see me as unfit to continue to provide care for my foster child? And then again comes a secondary wave of what if? What if I lose the child? How will that affect the structure of the family?
And when you're talking, it seems to me that many of these parents, or a percentage of these parents, it would be their first exposure to mental health treatment. So this is certainly something very new for them. So you have to kind of walk them through what's possible and what's going to go on there.
Sure.
But getting to the children, it would seem to me that one of the problems or one of the challenges for you and your staff is to gain the trust of that child.
Right.
And can you talk briefly about that?
Oh, sure. As I mentioned, it's traumatic for the child, and what you need to do at the time of admission is provide a series of techniques to engage the child, to increase their comfort level, and make them feel safe and know that they're going to be taken care of and receive the best possible care possible.
Some of these children actually have a little tick, do they not, where they're looking over their shoulders because they really don't trust people.
Startle response, or
You've got the term, I've got the description.
Yeah. Yep, that's
Well,
it.
Dr. Preib, thank you very much for spending some time with us and explaining to our viewers part of what we do at Maryville and certainly what we do at the Scott Nolan Hospital. And next month, Sister Kathy Ryan will be back, hopefully, and to continue with our next episode of Children First for Maryville. Thank you very much for tuning in.
My pleasure.